So I'm absolutely delighted to introduce Dr. Neil Ryan. He's a clinical lecturer and Gynaecology subspecialty fellow at the University of Edinburgh and NHS Lothian. His passion is to improve the care of those with gynecological cancer through prevention and personalised treatment. Neil's PhD was recognised by a President's Doctoral Scholarship, and he was awarded the highest honour from the University of Manchester, the President's Medal. Neil was recently also awarded the William Blair Bell Lecture from the RCAG, which is a fantastic achievement. And he's been invited to sit on several national and international committees. His work has led to a change in national guidance, as well as numerous publications, presentations, invited lectures and awards. So thank you so much for agreeing to speak today, Neil.
Oh my God, thank you very much.
Just before you start, the light behind you is just blurring what we see of your face. So I don't know whether you can close your blinds or something.
I'm afraid I can't.
All right, okay, no worries.
Thank you so much, and thank you for that very kind introduction. And this meeting is incredible. So it's my honour and pleasure to talk to you about really the surgeon's perspective of genetics in endometrial cancer. So surgeons are simplistic creatures. We've heard very much from the pathologists and from the very clever people. And so I'm hoping I can break this down to make it a bit more accessible and easier to understand for the surgical colleagues in the room. So what I'll go over is the molecular groups, which we've heard about, and I think that is really important that we do repeat this new revelation that's happened within endometrial cancer, because it is complicated, and only by repeating it do we get to understand it. Understand a little bit more about how we do the testing, because again, that's really important, because there are problems within the tests that we use. What that means for the biology, what that means for the treatment, and then just summarize everything so that we've got some take-home messages. So we've heard a lot about the molecular groups. I won't dwell too much on those, but it's just to sort of go over them again. So what we knew about endometrial cancer really 20 years ago was that we described it as type 1 and type 2. Your type 1 was your endometrioid, your type 2 was anything other. And we saw that there was an array of different histotypes with different prognostic implications. So we could see those sort of high risk histotypes really mimicking the ovarian cancers that we treat in our work as well. So things like the clear cell, the high grade serous, mucinous, all of those can occur within the endometrium as well. And then we had the endometrioid, which we kind of saw as a bit bland, but there was grade 3, which we considered high risk. And that's about as far as other speakers have mentioned our understanding went. Now, what happened next was that in 2010, the Cancer Genome Atlas, as Anna's already described, published a seminal paper, which absolutely revolutionized our understanding of endometrial cancer. And this slide is a slide I look at with more love and affection sometimes than my fiance. So that can cause some real issues back at home. But it is one of the most beautiful graphics I think ever produced in a manuscript. And if I just take you through it, there's a lot going on. But at the top, what you've got basically is different molecular markers divided into the 4 subgroups. So on your left-hand side of the slide is the poly ultramutated. In the next one along is your MSI hypermutated, your non-specific molecular profile, and then your copy number high, which is your serous-like P53 mutants. And that was all very clever. It was all very nice. We got to sort of break down endometrial cancer into 4 neat cohorts that fitted the histology and mapped on the genetics that we were beginning to understand more. But the thing that was really incredible and really beautiful is this Kaplan-Meier graph. So what you've got is progression-free survival going up there on the y-axis. On the x-axis is your months of survival that are coming along. And what you can see is that the molecular groups map beautifully in this cohort, and I want to really stress this, in this cohort onto progression-free survival. So we can see that your copy number high, that serous histotype that neatly mapped onto that genetic marker, didn't do very well. They had poor progression-free survival. Whereas your poly ultramutated, which seems to sit within the grade 3 endometrioid cancers, that had an excellent progression-free survival. And as you can see, pretty much at 100 months, there were no occurrences of recurrence, which is a remarkable finding. Now, the other groups there, your non-specific group and your MSI group, now they sort of were somewhere in the middle. They overlapped a little bit, but again, better survival than what was seen within the P53 mutants. Okay, so what this basically meant was that we could start to integrate things that we'd never thought about before. We could start to bring together the histology with the molecular profile and begin to map that onto the clinical picture for these patients. So we could start to say, okay, we've got endometrioid, adenocarcinoma. We think this is low risk because actually it's mismatch repair deficient. And so therefore we can start to wonder, can we treat these cancers in a slightly different way? Again, you could take a cancer group that was considered high risk in the past, such as your grade 3 endometrioid endometrial carcinomas. And if they had a POLE mutation, you could start to question whether or not these were actually low risk disease. And could that be mapped on to how we treat these endometrial cancers? And then when you saw your P53 mutants, you had to suddenly think to yourself, goodness, this is a very bad sign. This is very bad prognostically. Should we be treating these people far more aggressively, even in quite localized, small volume disease? Now, it's very important that we don't just take one study and one population or one cohort to make broad brushstrokes and change clinical guidance. So what was really exciting was that in the PORTEC-3 study, what they did was that they went back, they looked at their data, and they broke down their cohort into these molecular groups to see what happened to the progression-free survival in their cohort, to see if this finding translated into their cohort as well. And what they found was they pretty much got the same results. Now, there's always caveats with this. Remember that studies have inclusion and exclusion criteria. Studies are not real world. They are not what we as clinicians deal with all the time. And I will come back to that because we've got to be a little bit careful about how we apply these results without the trial evidence that is on its way. But it is very, very reassuring to see that the TCGA data, that genome atlas, that beautiful slide that I'm in love with, has been replicated and copied in an independent cohort and seems to carry true. Okay, so what happened in 2023, and there are controversies around this, and other speakers have spoken about it, and I'm not going to go into those controversies because I'm not a pathologist, and I think that would be overstepping. But what happened was that there's been such movement and such advance in endometrial cancer and such an increase in the molecular testing of endometrial cancer that FIGO felt it had to respond to this. And what it did was, for the first time, it included sort of genomic markers within its staging system. So you can see these two new stages, which are highlighted in blue, one meaning that we downstage disease if we see a POLE mutation. That's pathogenic, and I'll come back to what pathogenic means, and we've touched upon that with the last speaker a little bit. And we upstage our P53 abnormals or aberrants or mutants, lots of different terminology, which makes it really hard to follow sometimes. If we see that the P53 gene is mutated in a pathogenic way within our endometrial cancers. So that's all happened, and that's happened really quickly. And it's happened, if I can cautiously say it, without some of the trials we need to be confident in what we're seeing. Now, I am very pro testing. I'm very pro bringing genomics into our clinical practice, but we just have to apply the brakes maybe slightly here because we are sort of running before we've got some trial evidence. And the reason I'm slightly cautious is that there is lower grade evidence, but nevertheless evidence that we can see endometrial cancers with, for instance, in this paper, a POLE mutation, a pathogenic POLE mutation, behaving biologically in an unexpected way. And what I mean by that is that actually some of these POLE cancers did return, they did recur, and some of these POLE cancers did metastasize. So it's not completely clear yet if we can just say, well, it's POLE, don't worry about it. Because there is still some instances where we do see aggressive behavior from the POLE cohort. Equally, I think one of the other areas that people sort of took on board was, oh, if it's a mismatch repair deficient cancer, and more about that in a minute, don't worry about it. It seems to be, again, better prognosis, less aggressive behavior. Maybe we don't need to do nodes. Maybe we don't need to give adjuvant therapy. Ooh, what should we do about this? And again, the mismatch repair cohort is actually not a homogeneous group. When you think about it, there are 4 genes driving this, and there is another process by which you can lose mismatch repair expression, which is the somatic pathway, which is this methylation of the hypermethylation of the promoter region of MLH1. And again, lots of silly terms here, and I will come and Bax hasn't explained it a bit more, but just remember, the MLH1s that are hypermethylated, again, seem to be a little bit more aggressive than the rest of their mismatch repair cohort. So there is difference within these groups. They're not all the same, and we have to be a little bit careful. And again, what we can see in these papers and from these data is that sometimes the MLH1s actually are more aggressive than what we're expecting them to be. And the MLH1 hypermethylateds tend to be in older women, and they tend to be in more obese women. And so these are the women that are actually surgically more complicated for us to deal with, because obviously they have far more comorbidities and they are a much more surgical challenge if their BMI is increased. Okay, there's more coming down the pipeline. This is the scary thing for the pathologists. This is the scary thing for us. It's not going to stop here, everyone. We have so far talked about testing for one gene, looking at maybe a panel of genes, so a group of genes on a test. And what NHS England is doing now, and in consultation with, and this is really picking up pace, is talking about whole genome sequencing or whole exome sequencing. What is that? What the hell does that mean? Well, what that now means is they will sequence all the DNA. They're not going to just stop at sequencing a few genes. They're beginning to discuss the fact that the technology now is there. It's cheaper and cheaper by the day. Should we just sequence the whole thing and understand the entire genome of these cancers? Because we might find more and more targetable areas within these tumors that we can potentially drug or treat or have implications prognostically. The 100,000 Genome Project obviously closed a few years ago. The data is still coming out from that. There's been some really interesting papers. David Church down in Oxford is an oncologist that specializes in gynecological cancers and is really teasing apart these data in endometrial cancers. I think what we'll see is actually further breakdown, unfortunately, of those 4 groups, and specifically the non-specific molecular group. We're going to see that being shattered even more into different cohorts with different markers, with different prognoses. So it's going to get harder, everyone, I'm afraid. It's going to get more difficult. And the pathologists are going to have to, unfortunately, start to interpret maybe whole genome sequencing as well. So we'll see bioinformaticians being brought in, more and more information in our reports. So brace yourself is the take home of that. Now, I could not give a talk without talking about Lynch syndrome. Lynch syndrome is obviously the thing that I'm very passionate about. Lynch syndrome is an inherited cause of mismatch repair deficiency. It's autosomal dominant. What that means is there's a 50% chance of transmission between relatives, first degree relatives. And the thing that's really, really, really scary about Lynch syndrome is that it is really common. So about 1 in 300 people have it. We can think of what a room of 300 people look like, and amongst them, statistically speaking, one of them will have Lynch syndrome. The thing that's really, really scary about that is that the vast majority of them have no idea they've got it. They literally are walking through their lives with this inherited mutation that has made their mismatch repair system far more susceptible to breaking down, and then them developing cancers, a lifetime risk of about 70% for developing colorectal, and in some in the MSH6 group, about 60% of developing endometrial cancer, and they don't know anything about it. Now, say if you have a disease like Huntington's, where there's not really anything we can do, maybe not knowing is a good thing. But with Lynch syndrome, there's lots of interventions that we can do to mitigate that cancer risk. So by not knowing, we are doing a massive disservice to these people, because we can prevent them, hopefully, from getting a cancer in the future. There's effective interventions. And so what NHS England is now doing, and I now sit in Scotland, and there are differences between the devolved nations, but let's focus on NHS England. What they are doing is they are driving this campaign to find the 95%. And gynecologists are integral to that, because one of the cancers so closely associated with Lynch syndrome is endometrial, and to a lesser extent, ovarian cancer. So we need to be finding that 95%. And why? Well, because when we find them, we can do things to reduce their risk of cancer. So they're one of the key cancers is colorectal cancer. Colorectal cancer is highly lethal in this group. And if we offer them regular colonoscopy, which will now be part of the National Bowel Screening Programme for those with Lynch syndrome, we know that we can detect cancers that are precancerous, so in the polyp stage, or we can detect early stage cancers, meaning that they get far less aggressive surgery and have a far higher survivability. The other thing that's incredible is that aspirin, the thing that you just buy over the counter, the stuff that we sometimes take after having a bit of a heavy night out, aspirin can reduce your risk of developing a cancer. Oh, sorry, I think someone's got they're not muted. Sunitha, I think it's you. I'm calling you out. Aspirin, that drug that we can all find in Boots and other supermarkets as well. I shouldn't specify a supermarket. That drug can reduce your lifetime cancer risk in Lynch syndrome by 50%. That's from the CAP studies. So that's ridiculous. You just take regular aspirin. We're still trying to work out the dose, but you take regular aspirin and you reduce your lifetime risk of cancer by 50%. Now, that's specifically colorectal cancer, but there's also a signal seen in the endometrial cancers as well. And from the gynecology perspective, we know that we can offer risk-reducing surgery in the form of an in the form of a total hysterectomy and bilateral salpingo-oophorectomy around a time that is convenient for the patient. And actually now we're beginning to understand that Lynch syndrome is probably 4 syndromes driven by the 4 different genes. And so those with PMS2 and MSH6 can probably have their risk-reducing surgery post-menopausally when they have completed their family for sure. The other thing is, by knowing if someone's got Lynch syndrome, we can think about what surgery we're going to offer. If they're having a colorectal cancer resection, should there be a gynecologist there to do the risk-reducing hysterectomy and BSO? For the colorectal surgeons, they might also want to extend their surgery. Instead of just doing a segmental resection, they might think about more extensive colectomies if they know that these individuals have Lynch syndrome. And equally, if we are going to do an operation like a hysterectomy that might impact upon coloscopic surveillance, in very rare instances, there is also discussion about prophylactic colectomy in that situation if colonoscopy is not going to be feasible afterwards. Now, the other thing that is really controversial in Lynch syndrome is whether or not women with Lynch syndrome should have endometrial cancer screening. What I mean by that is, should they have regular tests, either endometrial biopsy, hysteroscopy, CA125, ultrasound, to try and identify if they are developing a ovarian or endometrial cancer, or indeed have developed an endometrial or ovarian cancer. And I think the take home from that, it's quite a complicated area to discuss, not enough time today, but the take home from that is that we do not have the evidence to strongly recommend that. But women with Lynch syndrome often find that very reassuring, but we don't know if it's harmful. So there's a lot of confusion around that topic at the moment. And if you want more, there's an article there that will describe that in more detail. Okay, who the hell should be offering women Lynch syndrome testing? When should we offer them Lynch syndrome testing? Who should be offering them Lynch syndrome testing? Well, work published by Emma Crosby's group a while back indicated that you can, as a gynecology surgeon, offer people Lynch syndrome genetic testing. And the best time to do that is after their surgery. So obviously, when they've got their diagnosis of endometrial cancer, they're extremely anxious. And when they are having their surgery, they're extremely anxious. But once they've received, the final pathology and the final sort of reports, they can have their germline testing at that point. And that can be driven by gynecological clinicians. Okay, so that's really important, because the move now, and we've seen this in ovarian cancer, it's working beautifully, is something called mainstreaming. And what mainstreaming is, instead of us doing the screening test, so the test that we've heard about looking at mismatch repair expression in the endometrial cancer, and then us referring them to clinical genetics seeing them, and then offering them a test for Lynch syndrome, that is there's a lot of links in that chain, and if one of those links breaks, the patient falls off the testing pathway, and we never get that germline test. So what we are hoping we can do now, and what the drive in England is that when you have someone who's probably got Lynch syndrome on the basis of their tumor testing, gynecologists say, look, you've probably got this condition. Here's some information. Could I take a blood test? Could we test you for Lynch syndrome? And then only those with Lynch syndrome go and see clinical genetics, because otherwise the clinical genetics are going to be overwhelmed. Okay, so let's leave Lynch syndrome to one side. Let's go back to this paradigm shift in how we're dealing with endometrial cancer and how we're classifying it. And we've heard a lot about this, so I won't dwell too much. But just remember now, instead of us just looking at the histology, the LVSI, morphology, all of those things, we now have to look at the molecular subgroups, because we do know that they're beginning to have they impact on clinical outcome. And we must, as an MDT, start to think about what that means for the ongoing treatment of these patients. Okay, a little bit about the testing, because all testing can give you a false positive and a false negative. So we should understand how we derive at the diagnosis of mismatch repair deficient endometrial cancer. The ways you can do it is you can either sequence the tumor, you can do microsatellite instability testing, which I'll explain in a second, or you can do immunohistochemistry. And immunohistochemistry is something we're very familiar with. Basically, if the protein is a bit faulty because the gene is it has an error in it, the protein doesn't fold correctly, and then the dye doesn't stick to it because it's not the right shape. So then the dye is absent, and you say, look, there's absent staining. There's a problem with the mismatch repair system here. And this is just an example of different immunos for different mismatch repair proteins. And I hope you can appreciate some of them are very dark brown, some of them are not very dark brown, and the ones that are not very dark brown, basically the protein is missing. It's a bit more complicated than that, but for the surgeons out there, brown good, no brown bad. Okay, the other thing that we found out through some work that I did during my PhD was that we thought this microsatellite instability testing, which is another genetics test, was really accurate in endometrial cancer because it's really accurate in colorectal cancer. So we just assumed it'd be the same. And this is an area under the curve graph. What you can see on the left-hand side, on the y-axis going up is sensitivity, on the x-axis specificity. And what you can see here is where different tests lie. And you can see actually that the immunohistochemistry highlighted in the triangle and circle has an incredibly high sensitivity and good specificity, whereas the microsatellite instability in endometrial cancer is much worse at detecting Lynch syndrome. So we worry that microsatellite instability is not good, and that's the current test that's used. There are new tests for microsatellite instability coming through, led by John Byrne in Newcastle. But the current test doesn't behave well, and that's why we don't do microsatellite instability testing as our first-line test in endometrial cancers, because it's not as accurate as we thought it was. The other thing we all need to be aware of is this thing called a variant of unknown significance. And what that is when we sequence a gene, we find a change in the code of the gene. So there might be TTT where we want AAT or something. And that means that there's a mutation. But does that mutation mean anything? Does it change the function of the protein that that gene is coding for? Because if the protein isn't affected, then the thing still works. It doesn't matter that there's a spelling mistake in the DNA. The protein is still working. And sometimes we can be really definite about this. We can say, look, this protein works fine. That is a grade 1, not pathogenic. And sometimes we can say this protein is beyond help. It is completely broken. That's a grade 5. So we know that's going to drive disease. But there are also these grade 3s where we just don't know. And we're going to see more and more variants of unknown significance where there is something picked up on the sequencing, but we don't know if it actually drives disease. And that's going to be a real challenge. And we are working hard to try and better define that. But that's something you might see in your reports. There's a variant of unknown significance. And then really what you need to do is involve specialists, geneticists, gynecologists, specialist interest, that sort of thing, molecular pathologists, to try and understand whether or not that's clinically significant. Okay, we should all be familiar with this, which is the nice guidance on testing endometrial cancers for Lynch syndrome and mismatch repair deficiency. Came out in 2020, has driven all of the mismatch repair testing we see within our local pathology departments. And this is the flow chart. I'm not going to go into it in too much detail, but basically test everything with immunohistochemistry. If MLH1 or or PMS2 or a combination of those two are missing, then you should be thinking about hypermethylation. So there's one protein you need to remember, MLH1. And if that is missing, think of doing this extra test, this hypermethylation. But if MSH2, MSH6 or PMS2 isolated is missing, then that could be Lynch syndrome. And we should be thinking, should we be testing this person for Lynch syndrome? And in England, you've got the Genomic Medical Service Alliance, which has embedded all of this testing into clinical services. You will have a Lynch syndrome lead within your MDT. You will have interested clinicians around your region, and you'll have a named Lynch syndrome leader within your region as well. So all of these things you can ask them, and you can involve them to make sure that you're making the right decisions if anything is confusing. Okay, biological implications. Now, this is a graphic that took me a long time to make, so there's often, it does come up a lot, so brace yourself. So I'm just going to try and explain what the mismatch repair system is. So when you are making DNA, when you're replicating DNA, you've got a daughter strand, a template strand, and you have you have errors that occur just because of the sheer volume of DNA that's being created. So here there's a mismatch error. You've got G and T, a great drink that you can enjoy tonight responsibly, but not what we should see. We don't see G and T pairing naturally within the DNA. So what happens is that the first dimer of the mismatch repair system comes along, MSH2, MSH6, and it says, whoop, there's a mistake here. And what it does is it highlights the spelling error effectively. MLH1, MLH1, PMS2 come along, and they chop out the wrong base pair. Boom, gone. And then that allows DNA polymerase, the author of DNA, to come along after this proofreading's been done and insert the correct base, adenine in this case, and that therefore means that we've got the correct DNA being created in the daughter strand. Now, what happens if you don't have this? What happens if your mismatch repair is all wrong? Well, what happens is you get loads of funny looking proteins because you get lots of spelling errors, you get lots of problems in the DNA, you get lots of proteins that don't look right. And proteins that don't look right often stimulate an immune response. So they are neoantigens, and they are cancer neoantigens, because if it's happening in the context of a cancer, the cancer is spilling out all of these proteins that look funny. And that means that these get presented by the dendritic cells. You get recruitment of the immune cells, namely cytotoxic CD8s, and they come along and they attack the tumor and they kill the tumor off. What that means is that for a tumor to be successful, it has to bypass the immune system. And the way that it often does this is through the PD-1, PD-L1 pathway, which is an off switch. It switches off immune cells. So if you express that, it switches off immune cells. So the immune cells turn up because they see that there's lots of new antigens. They try and destroy the cancer, but then they're switched off by the cancer because it's expressing the PD-1, PD-L1 axis. The other thing that we know from ovarian cancer is there's homologous recombination deficiency. And what we are now targeting with our PARP inhibitors is the fact that when you've got a double DNA strand breakage, that the way in which, and that happens commonly in your high-grade serous, your P53 mutant cancers, what happens is that they have to use alternative pathways to repair it, because often that system isn't working very well in DNA. So if we can switch off the two repair mechanisms using PARP inhibition, then we can actually make the cancer cells degrade and die and apoptose because they can't repair their DNA, and it becomes almost untenable, non-livable if you get too many mutations. So there's that happy medium in cancer of enough mutations to drive the disease, but not enough mutations that the cell becomes basically completely defunct. Okay, treatment implications. I'm aware that we have not too much time, and I'm aware that this slide has been shown. But what's starting to happen is that we're starting to very quickly implement treatment implications on the basis of the molecular profile of endometrial cancer. So we're now saying, oh, maybe you need to give chemotherapy in your P53 mutants. Oh, maybe you don't need to give radiotherapy in your polymutated. And we're trying to put together all these prognostic markers, so LVSI, molecular profile, morphology, grade of the tumor, stage of the tumor, all of that stuff. Trying to put that together and make a coherent pathway that puts our tumors into low risk, intermediate risk, and high risk. And that categorization will then drive onward treatment. And this flowchart is busy, and it's busy on purpose. And it was developed by a colleague of mine in Bristol, Dr. Albuza. And what this shows is basically, this is how you implement the ESGO guidelines. So if you take stage 1 and we go down A, does it have LVSI, positive LVSI regardless of depth, that means it's high risk, okay, and it will need extra treatment. But if it doesn't, and if it's got low grade and it's low and there's no mutations that are worrying, it's low risk and it might not need any adjuvant therapy if it's stage 1. So what this slide is just there to demonstrate is the complexity of trying to make treatment decisions in the current environment where we've got all of these different factors to look into. And this is a slide that I think you should all go away and have a little look at, and maybe at the MDTs, try and track your patients through it to try and work out where they sit in this categorization of high risk, low risk, and intermediate risk. And one of the key questions is, as surgeons, should we be taking out nodes? Should we be doing pelvic lymph node dissections in polymutant tumors? Now, often we don't have the result before we do our surgery, so it's not that helpful. But that will get quicker. And the other thing I've got to be really cautious about here is that we don't really know, because at the moment we don't have the data needed to tell us what happens if you don't treat these people on the basis of the molecular profile. Because if you think about it, all the people from the TCGA, all the people from Portec got adjuvant therapy. They were being given treatment as they would have been regardless of their molecular profile. So we still don't have the trial data to know what happens if you don't give them adjuvant therapy. Do they come back? Or is it just that they behave much better when they get the therapy that we are routinely giving? Final thing then, just to sort of focus on, is immunotherapy, which is really the realms of the oncologists, but I will just try and touch upon it and really just highlight how important it is to remember that advanced or recurrent endometrial cancer is a lethal disease. Okay, lethal disease. Less than 20% survival at 5 years for patients with advanced or recurrent endometrial cancer. So this is a group of patients that we are not serving well with our current treatment. What is exciting is there is new treatments available. NICE has talked about dostarlimab. There are other checkpoint inhibitors out there, which seem to be very effective, specifically in mismatch repair deficient cancers. So not just testing endometrial cancer now for mismatch repair deficiency to find Lynch syndrome, but identify a cohort in whom we can offer other lines of treatment after they've had their standard lines of treatment. Sometimes we use PD-L1 as a marker to direct immunotherapy. Actually, meta-analyses data would indicate that PD-L1 is not very helpful in endometrial cancer. So we should be using mismatch repair deficiency to identify those who are amenable to immunotherapy treatment. Two key studies that you can go away and have a look at: the Garnet study and the Ruby study. And the key bits about these studies, I'll just draw out some of the key data from these studies. First of all, in the first study, the Garnet study, which was a phase 1 study involving 143 individuals who were given a checkpoint inhibitor after given a checkpoint inhibitor in the context of advanced or recurrent endometrial cancer, remembering that most of those women will go on to die with the current paradigm of treatment. In this, we saw an objective response rate of 45%. That's remarkable. That is remarkable. That is not what we expected at all. And disease control rate of 60%. So these treatments are having a massive impact. Garnet turned into Ruby, and what Ruby found was actually that you can use these checkpoint inhibitors in endometrial cancers, and you see a significant response in both the mismatch repair deficient and proficient populations. So they seem to have an effect in both, but that effect is far more pronounced if we look at these Kaplan-Meier groups in the ones that are mismatch repair deficient. So what you've got on the left-hand side is progression-free survival. On the right-hand side is overall survival. The top line is those treated with a checkpoint inhibitor. The bottom line in blue is a placebo group. And you can see that in the mismatch repair deficient at the top, there is a massive separation of those lines, a big improvement in progression-free survival and overall survival. And you can also see that if I draw your eye to the bottom of those three tables, that also happens within the mismatch repair proficient group. So this is something the oncologists are getting very excited about. There's now a new treatment pathway available for the advanced and recurrent endometrial cancers. And that means that we are getting new treatment guidelines, and those are clearly specified in ESMO, and we should start thinking about checkpoint inhibition alongside our routine therapies when our routine therapies have failed. And maybe, and we're getting more trials coming through all the time, maybe we should be using these checkpoint inhibitors up front in our first line treatments. For the surgeons, maybe, and again, this is a maybe because there's no trial data to support what I'm about to say, so don't go and put this into clinical practice, but maybe in those women with a mismatch repair deficient cancer that we can't surgically operate on and progesterones aren't working, maybe they are amenable to checkpoint inhibition. We don't know, we need to go and explore that, but it's all very interesting. And the other thing from the surgeon's perspective, something I want to highlight, is that mismatch repair deficiency can happen during the course of a cancer's evolution. Now, it's rare, but it can happen. So the question there is, if you have a mismatch repair proficient endometrial cancer at the diagnosis and it recurs, could the recurrence be mismatch repair deficient? Should we be rebiopsying to try and work out if that tumour is now susceptible or particularly susceptible to mismatch repair deficiency? Now, you may make the argument that you're going to give the immunotherapy to mismatch repair proficient and deficient in the future anyway, so you might not need that repeat biopsy. But at the moment, it's useful information. We should be thinking at the back of our minds, in recurrence, should we rebiopsy? And we've talked about the Rainbow study a little bit, but there's a study coming through now looking at the different treatment arms that we can offer people with endometrial cancer based on their molecular profile, with the use of PARP inhibitors in the p53 mutants, the use of checkpoint inhibition in the mismatch repair deficiency, and the use of progestins in our non-specific group, and actually de-escalating those with POL-E. And also PORTEC-4A is going to publish soon. I hope there's no results currently. But again, these are the trials that will give us the confidence to change our treatment based on the molecular profile. We don't have them yet, so we need to be a little bit cautious, but these trials are coming soon. And the last thing I just wanted to mention was that, really excitingly, and this is the future, I think, for Lynch syndrome, they are constantly making these bizarre proteins stimulating the immune response. And so there may actually be a vaccine out there, which is, lots of people are trying to develop one that would vaccinate people with Lynch syndrome against their cancers, which is a crazy idea, but that's out there. So I'll summarize. Genomics is already here. We need to be fluent in genomics. We need to understand what these tests mean. We need to understand their pitfalls, and we need to understand their implications. Clinicians are going to drive this testing. So we need to be thinking, okay, how can we make this more streamlined all the time? We need to be thinking, can we, instead of referring everyone to clinical genetics, do the Lynch testing, do the other testing, and get the results back, as we do with BRCA testing in ovarian cancer. And we should start to see results driving treatment, but we do need more trials, and we do need that data that's coming from Rainbow and from Portec 4. So that was a whistle-stop tour of genomics in endometrial cancer. Thank you again to the organisers for the opportunity to present. It is an amazing meeting, and I'm very humbled to be able to give a talk as the SST up from Edinburgh. So thank you very much.
Neil, thank you so much. Your enthusiasm is infectious. I'm absolutely blown away by that talk. So well, thank you very much. That was brilliant. So we got any questions at all?
Dr. Hawari has a question.
Yes, sorry. Yeah, I've never seen anybody enthusiastic about molecular like the fact that you like that graph so much is
I love that graph.
amazing. You reminded me, like my husband said, you said Genexus more than my name in the last 2 years. I just one thing, I don't know if you came across, I've been in a talk about Lynch syndrome recently, and they mentioned about opportunity for patients who are Lynch carriers and they want to have a baby, that there's something available on the NHS that they can actually test the embryo and only implant the embryo which does not carry Lynch, because we know there's 50% chance of passing it on. So I thought this is something for the audience to be aware of, because it's I thought it's such a great idea for the women who want to have babies.
Yeah, so pre-genetic diagnosis is available, and it's something that can be offered to women who, or male partners, a couple that has got Lynch syndrome within the couple that's been diagnosed, and that's done within the fertility services. There's obviously some ethics around that. There's quite complicated conversations that need to be had around that, but it's definitely available on the NHS.
Yeah, it's excellent.
Any other questions at all? Hold on, there's a further hand up. Mai, did you want to turn your camera on and ask your question? You're muted.
Well, can you hear me now?
Yeah, good.
That was a very, very interesting topic. Thank you very much. It's actually very well explained. So going back to your molecular classification and the guideline, with the fact that there are a couple of case series reporting recurrences with poly tested endometrial cancers, is it still then advisable to manage these patients? There was a paper from Sloan Kettering saying that they've had a case of about 17% of recurrences from those that have been deemed low risk. And so they've decided not to adhere to the guideline. And I'm just wondering if that's something that we should take seriously, because 70% is quite a very sizable number. Thanks.
First of all, I really like your outfit change. I think that's brilliant. I'm expecting a different coloured scrubs when you come back on the call next time. So this is the thing that's really important. So what you've got to remember is in the TCGA, these were women treated with all the treatments that were prescribed at the time. So if they were high risk, they got radiotherapy. So you're seeing the poly group not recurring, but they were getting all the treatment that we'd expect them to get. And then again, the other follow-up studies that have confirmed the findings of TCGA, this was in the time where we weren't doing the testing. So they got the treatment that we'd expect them to get back in the day. So all we can say from these studies that we have at the moment is if you give women with a poly mutant endometrial cancer the treatment that would have been prescribed not on the basis of their poly mutation, they're less likely to recur than the women that don't have that. What we don't know is if you de-escalate them, are they safe? And that's why Portec 4 is out there. That's why Rainbow's out there to answer that question. Until they report, I am very cautious about us changing any of our treatment on the basis of a molecular test, because we don't have the data. And we've all got really carried away with this, and we've all started to run with it. And I think that we just need to hold fast. And this is why I think the FIGO 23 reclassification is a little bit anxiety provoking in me, because again, I think that we're starting to sort of believe our own hype without going back to what the actual data says. And we've got very excited about it. We want to stop these women from having toxic radiotherapy, but we don't know if that's safe.